I just love these little problems, because if you run a clinic with common problems, we used to call it the seen and admired clinic, because there were lots of kids in there, you know, with sort of, you could see them, you could admire them, say, aren't they beautiful, aren't they doing well? And just occasionally, you have to look out for the classic, because mostly what you see in a seen and admired clinic is nothing but normal variance. But occasionally, there's some pathology there. Most things are within normal limits. Occasionally, there'll be an abnormality. And then the tiptoe walking, it's the classic. And if it's unilateral versus bilateral, or if it's really quite asymmetrical, then perhaps you should start being concerned. So by definition, a tiptoe or toe walking gait means that you're walking on the balls of your feet, and there is no heel contact during gait. It's totally normal part of development. But if it's going to be normal, it should be gone by the age of 3 years-ish. If you're presented with a child with a unilateral tiptoe gait, you must find the cause. You should exclude DDH because it's treatable and it deserves to be found early. So if there's any suggestion from an early age, then this might be an example when you might need an X-ray or an ultrasound, but something to absolutely put to rest the idea that this is a DDH that you've missed. And of course, you also might be thinking about a major limb anomaly. But the major limb anomalies, such as this kid's toe walking, they will have been picked up before. What you're looking for is a more minor form of a congenital anomaly which might have been missed, which is why it's presenting to you as a common orthopedic problem in your office. So unilateral, find the cause. There must be a cause. This is not idiopathic toe walking. You want to think about neurological conditions. Again, the barn door obvious spastic diplegia will have been picked up before, mostly. What you're looking for is a very mild asymmetric diplegia or a mild hemiplegia. You want to look at the upper limb posture and their reflexes, tone, and maybe their leg length. Get them to run around, move around, and as they're walking, do they become more tiptoed? Is the hip and the knee flexed, and is the arm coming up into a hemiplegic type posture? Keep your eyes and your ears open. And of course, always think about spina bifida as well. So in the unilateral cases, it's easy. Find the cause, and then that will direct you in your management. If it's a bilateral tiptoe gait, then again, you're supposed to find the cause, and you must really look at the whole child, and there is no excuse for not doing a formal full examination. And this child standing beautifully high up on her tiptoes with straight hips and knees. So idiopathic toe walking is persistent tiptoe gait for no known reason. That's why it's called idiopathic. It doesn't mean there is no cause. It means the cause is not yet known or found. But it probably is a central nervous system problem that is driving your tiptoe gait. You will then have secondary problems due to that drive, but the primary problem most people feel is centrally. It's a diagnosis of exclusion, so you must go through what I used to be taught as a surgical sieve: congenital causes, acquired, metabolic, infective, traumatic, blah, 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 blah. And you must go through that surgical sieve to ensure that you've excluded all the causes of a tiptoeing gait. And if you have, then it's idiopathic. It's slightly more common in boys. There is often a positive family history, and some people would say that if there is a positive family history, then it's a more severe tiptoe gait. I don't know if that's true. Another paper showed that the tiptoeing gait children have a higher rate of prematurity and a higher rate of special care baby unit admission in the neonatal period. And that would go around along with the fact that it is a central origin for the tiptoe walking, and maybe the borderline between an idiopathic toe walker and a very mild diplegic cerebral palsy is extremely blurred. The key is, of course, as with every child, is that to take a full history. You want the birth history, the neonatal period. Was there anything unusual? Did the family just say in passing, oh, the child had to have a head scan while they were an inpatient? That's not quite normal. Why did they need a head scan? Even if it was normal, why did they need it? Were they on the special care baby unit? If so, was it just because they were being taken good care of, or was it because there was actual concern that there was an underlying abnormality? You want to know the early developmental milestones, their walking age, and were they tiptoeing from the start? And has it always been symmetrical? Tiptoeing from the start is allowed to be idiopathic toe walking. Toe walking that comes on later is not idiopathic. If you look, you will see. So again, you're going to observe the child's general behavior, their walking pattern, their standing posture. You're looking for symmetry, and again, the associated arm movements. Always look proximally. Don't get caught out by just looking at their feet. We're looking for the ankle rockers, aren't we? The first rocker after the heel strike, when the ankle plantar flexes and the foot is lowered to the ground, and that's the tibant contraction. The second rocker, when you're standing, you then need to be able to have progressive ankle dorsiflexion to allow the tibia to come forward, to allow you to start for your push-off. And that's controlled by your third rocker. So again, these are the bits that you're looking for in a tiptoe gait, which will not be there. So when you're examining the child and their toe walking, are they doing it all the time, or is it intermittent? Can they stand still? It's very difficult to stand still if you're on your tiptoes all the time. You have to go around like this unless you can get your heels to the ground. Have they got a tight Achilles tendon or not? Have they got enough dorsiflexion for that second rocker? Have they got a triangular foot or not? So most footprints look like this, with a heel contact and a forefoot. But the idiopathic toe walkers often have a triangular foot, with a small, narrow heel with no callus on it and a broad forefoot. Have they got a tight Achilles tendon? Can they get their heels down? Many children can only get their heels down by abducting and externally rotating their feet. And they often cheat also by having hip flexion. The natural history of idiopathic toe walking is not completely clear. We think it disappears with time, or it certainly becomes less obvious, or it may become disguised as a flat foot with a tight Achilles tendon, so the heel breaks into valgus position. Or you might see someone who's sort of bouncing down the street in London or Mumbai, and they will be a toe walker, which hasn't quite resolved completely. As far as treatment is concerned for idiopathic toe walking, there are lots of options, but not much of an evidence base. And it depends on whether or not there is a fixed deformity, and if so, if you want to correct it. And I think the management of toe walking is also a matter of philosophy. So my aim would be to obtain a plantigrade foot and allow for some stability in starts. So if you can't get your heels down, I think it's a good idea to do something that will allow the heels to come down. Is your aim to encourage heel-toe walking? The abnormality is proximal or central, so simply getting their heels to the ground may not allow a normal walking pattern to develop, but it may facilitate it, and the child may be able to learn to walk in a heel-toe pattern. So my philosophy is, if there is fixed equinus, I might do a careful percutaneous triple cut of the TA or an open fascial lengthening of the calf complex. I have them in a Bologna walking cast for a relatively short period of 3 weeks, and I don't really go for early physiotherapy. And I warn the family that things will look much worse before they get better. So they're used to their child tiptoeing around, dancing around on their toes. After any surgical procedure, they will be very flat-footed for a while, and they will barely be able to go into the plantar flexed tiptoe position. And they will look terrible as far as the family are concerned. But you must reassure them that gradually the strength will come back and the pattern of walking will hopefully stay heel to toe, but may not do. The research treatments include a variety of different techniques, including things like sensory motor insoles, body vibration, prism lenses, all these sorts of things, Botox injections, AFOs. There is no good evidence to support any of these treatment modalities. So the only treatment that might work is to lengthen a tight Achilles tendon to get a plantigrade foot and then decide whether you can try and adjust the walking pattern. Common sense would tell us that there is behaviour or habit may play a part. I don't think this is habitual toe walking, it's idiopathic. It's not a habit that I am left-handed, it is ingrained in me that I am left-handed. It is not a habit that the child toe walks, it's ingrained in them that they toe walk. There may be a sensory motor processing error, and there is a strong association with the autistic spectrum disorders. Does that matter? Well, I think it does in terms of diagnosis and expectations of treatment. Then there's another group of toe walkers who are late onset or late recognition. Look at the early photos if you've got any. Is this a regression in developmental milestones? If they've become a toe walker, you need to know why. So you need to look for tethered cords, for Duchenne's muscular dystrophy, and autistic spectrum disorder. And again, with the late onset, it's all in the history, a complete full examination, and then the investigation is appropriate to make sure that you've excluded the neurological conditions that you're worried about. And the Gowers test is one that you should all be very familiar with, and you should have the child starting off lying down on the floor, watch them turn prone, go to 4-point kneeling, walk their hands back towards their feet, walk their hands up their legs, stand up in a wide-based, externally rotated gait and looking slightly awkward. So the tiptoe gait, it's common. It's either something or nothing. Identify the something. That's your prime role. Don't over-treat the nothing. And ask for help if you think there may be an underlying neurological problem. Reassess and reevaluate. Thank you.